breaking barriers and bridging the gaps between patients and doctors. Welcome to Brainstorming with the Docs and your co-hosts, Dr. Glenn Harrison and Dr. Kolby Condos.
Hello, everyone, and welcome back to this week's episode of Brainstorming with the Docs. I'm Dr. Kolby Condos, my co-host, the man in black, Dr. Glenn Harrison. And today we have a very special guest, my friend, Kaylee, who is a recent graduate and a new nurse practitioner who has been working the past 5 years as an RN in healthcare. So a lot of our patients are always asking us for questions as far as like, who do we refer to? What are some benefits of seeking out natural care versus allopathic care? What are some limitations? What are some weaknesses of both? So today we decided that we were going to go and get someone who practices every single day in the Western medicine healthcare model and talk to them, break it all down, and give you guys some answers. If this is your first time listening or tuning into the podcast and you have questions about your own health or common healthcare conditions, hit like and subscribe, turn on the notifications so that when we come out with new content, you guys are the first to know. Without further ado, Kaylee, introduce yourself.
Hello, everybody. My name is Kaylee McCulley. I'm a newly graduated nurse practitioner. I've been an RN now since 2012, so it's been a long time. And I'm very excited to start practicing as a nurse practitioner very, very soon, hopefully.
Well, and now you're on our podcast. So this is exciting. Kaylee. And the little bit we talked about, I was kind of explaining of what really we wanted to discuss on this podcast. And I think you did a very good job with Dr. Kolby. But just to, again, break down some barriers of what people experience on both sides. Because I've learned over the years, and I know you've seen it from your side of the aisle, and Dr. Kolby and I see it from our side of the aisle, where people come into the medical setting or the natural setting, or they have a problem, and they feel like they either have to go to the medical doctor or go to the natural doctor. And they feel pulled between both ways. And sometimes they believe it's all or none one way or all or none the other way. And it creates a lot of frustration, a lot of uncertainty from their side, as well from the providers, for what can be done, what can't be done, and to kind of clarify the experience of both sides. So I think I'm kind of on track with that. Would you say, Dr. Kolby?
Mm-hmm.
Oh yeah, I would 100% agree on that. So Kaylee, what are some like limitations or issues that you see in the model that you're currently practicing in?
It is I would say a lot of the patients that I see come in for a specific reason and they want a quick fix. So in that case, there's a lot of prescriptive medications. They want things to be done right away. We like to talk about diet and exercise, and I've had a few patients kind of laugh in my face being like, well, that's going to take too long. I don't want to do that. And they really come in and they want it fixed now.
I feel like that's one of the reasons why MDs, FNPs, NPs, whoever in traditional Western medicine settings have such a hard time with patients because, like you said, they want that immediate impact. They want that immediate result. And a lot of times when they have their own skin in the game, they're not as compliant or they're not going to do it as quickly. So when it isn't the silver bullet is what I like to call it, right? So they want the silver bullet. They want the answer to everything. They want one pill to cure it all. They don't want to have to change their lifestyle at all. The issue with that is that then they get frustrated when that doesn't happen. When they don't get that magical relief that they were looking for right away, when they actually have to do things like start getting some exercise or change their diet a little bit, they get a little bit frustrated. And the results are a little bit slower. We know that to be true when you have to implement those lifestyle changes. But I feel like that is something that Western medicine doctors or traditional MDs or anything don't have any control over as far as patient compliance. I feel like when they start to come into our realm, when they start to get desperate enough where they're like, okay, I've tried all the medications, they're not working. Then they are a little bit more susceptible to that. They're a little bit more willing to implement those day-to-day activities such as diet and lifestyle changes to make the changes and help. What do you think, Dr. Glenn?
I think we, as human nature, we always try to find the shortcut and the most efficient path to get to the outcome. Once we exhaust that and we get that frustrated experience, then we're like, well, because that doesn't work. So I guess I'm going to try it this way. And then I know on our side of the aisle, on the natural side, we see a lot of people that are already exhausted. They're already burnt out. They feel like they've been promised a bunch of things and didn't get the outcomes they want. So now they're on their last leg. You see that all too often. I know you see it in your clinic, Dr. Kolby, and it's just because they set themselves up for a strategy that maybe wasn't the right fit for their specific ailments and concerns. But they wanted to exhaust the quick strategy, if there is a quick strategy first.
Agreed. Is there anything else that you see that, or how about this? Anything that frustrates you about the way that you're forced to practice or the way that you practice right now?
The biggest thing, I really like to focus on prevention and not having my patients get to a point where they need to seek out more extreme measures. And so I just feel right now that most of my patients that I see are coming in with something already going on, a disease. And I really want to focus on the prevention of that. And that's what's just very frustrating is always my patients just, sorry.
No, you're good.
Yeah.
Yeah, we've talked about that before. And the fact that was one of the bullet points that we talked about last time is when you see a patient and you're in the model that you're in, there's already something usually significantly wrong. You're not getting them on the front end of the disease. You're getting them when they're smack dab in the middle of it. You're not seeing someone who's pre-diabetic. You're getting someone who's already full-blown diabetic. You're not seeing someone who maybe has some respiratory issues. You're seeing someone who has already developed substantial respiratory issues. And I feel like that would be really a struggle for me as a provider personally. If I had something and you're like, there's all these things that we could have done 9 months ago to keep you from getting where you're at right now, but we didn't do that. I feel like that was part of the reason that we decided to do this format for this podcast, is because Dr. Glenn and myself, we only have one set of lenses. We only see things, no matter how much we want to try to see things through a different light, we are already predisposed to our biases. And because we haven't practiced in that specific setting, then we don't really understand. I mean, we can empathize a little bit, but we don't really understand at the level that you do why it's so frustrating to deal with patients like that.
Yeah, they're kind of set up in a situation where they're told one thing, but in reality, the model can only offer them a certain thing. And then I can imagine sometimes you maybe feel your hands are tied with what you can do, correct? Time constraints, etc. Yeah.
Yeah, I think that's another thing we talked about. I mean, I don't know what your average visit is as a healthcare provider, but I assume it's less than 10 minutes per patient, because it's like, it's a business, you know what I mean? And the business has got to keep running. So it's got to be patient after patient after patient after patient after patient. That doesn't really leave a whole lot of time where you can sit down, get to know the person or the patient on a personal level, and you can help them implement some of these things that you would like to change. You know, I can only imagine how frustrating it would be. It'd be like, oh, we need to put you on a diet. Well, what kind of diet? All right, I got 3 minutes. I'm going to shoot you an email with some of the stuff that I think that you should start to implement. So I think that would be a difficult constraint as well.
And then where does the time come for that email?
Yeah.
At night,
the end of the day, right? Then you have like 9 million emails to send out.
Yeah. What a quick snapshot, if you're willing to share, what is the percentage of time with a client versus how much paperwork? For every hour of client time, what would that equal to with intake paperwork, charting?
I would say as a new practitioner for me, I like to look at kind of things, look up things before the patient comes in. So that takes time. And then I would say it takes for me about a half hour for documentation. And again, that's as a new practitioner. But I would say more experienced providers, it might take them 10 to 15 minutes to dictate a note.
Okay. So if you're seeing a patient every 10 minutes, so you see 6 patients an hour, you have an extra hour of paperwork on the back end.
Correct.
If you work an 8-hour day, you have 8 hours of charting afterwards.
Yes.
Yeah. So think about that.
Wow. Yeah.
So those are some limitations associated with the Western medicine model. Why don't we talk a little bit about some of the issues that we see in our model, Dr. Glenn?
Well, I don't know where to start. I think I think as we were talking before the start of this podcast, a lot of patients when they're dealing with these chronic illnesses, they're in the medical system that has a hard time to provide as much empathy as they require, being heard, just because of the machine that these providers are trying to sit in. And again, I'm not on the front row of that. I don't have front row seats to that, but I do see there's this starvation for empathy when they come in. So there's this massive emotional burden that they want to dump. And then it turns into not only the clinician side, the motivation, the regaining trust, the looking at it from a whole other set of lenses and trying to educate on that, but this big emotional burden attached to it with chronic illness. And I guess that works on both sides of the aisle, and not just with us. But I think that's some of the challenges, just to name a few. And then the other burden that I find is letting my clients know that I'm not fixing you. I can't cure you. All I can do is guide you, give you the structure, give you the direction, give you the motivation, do a little bit of cheerleading now and again, and point you in the right direction. And that's as far as I can take somebody, and get feedback and communication, work as a team. I can't cure. So I think there's the, fix me model, and then they come in and they're like, oh, doctor, fix me. I'm like, no, that doesn't work here. That's not the way it works. Lifestyle medicine. So I think that's one of the big hurdles for many people to get past.
Yeah, I call it the architect contractor model, right? So I'm the architect. I'm going to show you what to do, and then you're going to go home and do it. Because I can't teach you how to cook. I can't be with you to rah-rah you to get up in the morning and exercise. So there is a certain amount of personal accountability that people have to have in order to seek out this type of care. I think that one of the things that I have found is that people, because we practice more natural medicine, a lot of times insurance doesn't have the same coverage as it does in allopathic medicine. So people in a lot of times don't want to have to spend money. They're very, very emotionally invested in their money. So when you tell someone, all right, it's going to cost us this much, people are like, oh no, I'm not going to do that. What, my insurance not cover this? Well, maybe not. So I feel like that's a huge hurdle for a lot of people. I also think that there's a big hurdle in the fact that while it's getting better, there's not a lot of consistencies across providers. There's some providers that do like a great job. They've gone through tons and tons and tons of schooling. They have all the credentials in the world. And then you have another provider that, took a weekend seminar, and then all of a sudden they're going to try to start doing this stuff on the side. And I don't think that that's necessarily fair to the patient in a lot of cases. I think that that's why it's really important for the patient to, like, in a way, interview their provider and make sure it's a good fit, make sure that they feel comfortable, make sure that they feel like they're qualified to take on their case, because there is a lot of inconsistencies across professions when it has to deal with natural medicine.
Exactly. There's no standard. There's no true standard of care in the natural model. There's so many different approaches and ideas and concepts and strategies that, and I think that's what really held natural medicine back. But I also think it's an opportunity that gave natural medicine an opportunity to think out of the box and not just have a certain set of rules that are a certain protocol for every different piece. So I think it's a blessing and a burden.
I would agree with that. Yeah, for sure. So here's the $1 million question, and the main reason that we actually wanted to do this. Kaylee, how do you feel like the patient would improve if we were to start coordinating care between natural and allopathic medicine?
I think it would lead to much better patient outcomes. Working together, I think we both bring different ideas on how the patient can become healthier and how they can work on what's ailing them. But I think coming together and having both sides would just be the best for our patients.
I completely agree. When I'm teaching people about what my thoughts are on their case, if someone comes into my clinic and 90% of people coming into my clinic are on some form of medication, 1 or 20, that's just the nature of their illness. And I'm very quick to tell them that, you're pursuing natural medicine, but we could find something in your blood chances are we will, that there's going to have to be medical management on this. And if I have a patient that comes in, they say, no, and they're not on drugs and medications of any kind, they maybe need them. And they say, no, I'm not, I can't go to the medical doctor. I don't want to. Well, I usually show them the door, because there is a place for these things. So again, a lot of people believe they only can go to one or only go to the other. And a lot of providers, medical and natural, well, a lot of natural, they try to say we're integrative. Well, true integrative medicine is integrating everything, not just integrative medical, not just integrative natural. So I think as we're seeing more and more medical providers like yourself, they're open to these things. Like I was saying at the start of this podcast, I was saying that, or before the podcast, the most common profession that I see in my office as a patient is nurses. And lots of reasons we could have another podcast just to talk about the challenges of nurses, and you'll be spotlighted. You'll be in the spotlight. But I think that deviation of people feeling they have to go one or the other, or they get a provider, and there's natural doctors saying, oh, those medical doctors are crazy. Those guys, they're crazy. They're just standing around with scalpels and pill bottles. And then there's the medical doctors say, oh, those guys are quacks. They've got marbles and shiny rocks, and they're talking about which way the sun's coming up that day. It's funny. It's crazy. And you're laughing because it's true. You got crazies here and you got crazies here. Not all are crazy on either aisle. There's some very intelligent people in these crazy groups. But when you have a patient, and I've had patients like that, where oh, I just got a notification. When you get these groups that come together, the medical and natural providers say, hey, we're going to be a team here. We understand your emergency care, and you're going to be the best with the emergency care. There's emergencies in life, right? Mm-hmm. And that's good. We're going to have it, and they're going to guide everything, all of the medical, and then we got natural medicine that hopefully we can keep you out of emergencies, but you got to have it when it's needed. So I think as we're I don't know, say maturing in these professions and getting more overlap, like we're talking about right now here, we're communicating like this, the patient outcomes are significantly different.
Yeah, I think too that we need to understand that there are certain situations when you actually do need a pharmaceutical intervention. You know, if you have, say you have a movement disorder and it's got progressed really, really far, then yeah, that might be an option where we look at a pharmaceutical intervention or some sort of surgery or something like that. So I think being able to differentiate that it's not all bad and it's not all good. And there's it's not that I'm anti, it's that I'm pro-appropriate use and pro-appropriate situation when it is used. So I think that when you look at, you need both of them. You can bet if I broke my arm and I had a compound fracture and the bone was sticking out of my arm, I probably would go to the emergency room. I think that that's a perfect situation where you need to understand that there are situations where you need both. And there's certain times where there might be something that's over your head, and it's okay to go to someone who's more involved or who has more knowledge about it. That's the whole point of having the referral system. So I agree with both of you guys. I feel like the more you integrate, the more eyes you have on a situation or on a disease or a patient, the more integrated you get, the more options that they have available to them and that are afforded to them, the better they're going to get. Because not only are they going to have the pharmaceutical interventions, but then they're going to also have the support for the diet, the lifestyle, the exercise, some neurological treatment that is neurorehabilitative in nature instead of being like surgical or medication. You get all of these different facets to their care, and they're going to get better, and they're going to get better faster, and they're going to stay better longer. So
when there is an emergency, then it's not too significant of an emergency. They're going to bounce back a lot quicker. But
right. And the referral system's already in place, right? So then, like, if it's all integrated, then it's like, I have a patient and they're degenerating really, really quickly. They need. I think that this might be a pharmaceutical intervention time. Send them to Kaylee. She takes care of them. It's all done. You already have built this relationship of trust. You're all familiar with each other. Mm-hmm. Everyone knows where everyone's at. Everyone's on the same page. I think we all need to understand, and everyone who listens to this needs to understand, every healthcare provider wants to do the best job for their patient. They want to get their patient better. They want to see their patient live a vibrant life. They want to see them live a long life. They want to see them live a fulfilled life. So when you get these stories about, I had a terrible experience with this. Well, that was just that experience. And that provider, for the most part, probably didn't have ill intent towards you. They wanted to get you better. They want to get you healthy.
Yeah, that's exactly right. And I think as providers from both sides of the aisle start to have more conversations with their patients, that, we're going to take on this part of it, but if you want all of this, you're going to have to see somebody like that. I have people in my network you can talk to, and then the patient isn't caught off guard. Well, I thought you were doing everything. Or Dr. Harrison, Dr. Kolby, I thought you were doing everything. No, everybody has a different set of tools, and as long as the patients are informed, I think it'd be a streamlined process where everybody wins. So yeah, but I'm very grateful for everything you do, and I'm glad you graduated. That's exciting.
Thank you.
I know. I want you to get up here so I can start sending people to you.
I know. It would be my dream to work with you someday.
Well, we can maybe make that happen eventually.
We've got it recorded, so we're holding you to that dream.
Yeah.
That sounds good.
So thanks for being on, Kaylee. We really appreciate you. Congratulations on graduating. Super, super proud of you. And I'm sure we'll collaborate in the future, not only on podcasts, but also for our patients. Again, if this was your first time watching the podcast and you got value out of this, like and share it. Share it with your loved ones, your friends, your family members. And again, stay tuned because we're going to keep rolling out these episodes of Brainstorming with the Docs. If there's something that you guys would like us to go over, drop us a line at info@info@brainstormingwiththedocs.com. Or you can get on our websites, www.northlakescheropractic.com. Dr. Glenn's is www.drgharrison.com. If you Google Brainstorming with the Docs podcast, we have a YouTube channel. We're on Spotify, Apple, everywhere. So turn on notifications everywhere. So, all right, guys. Well, this was fun. We should definitely do this again. And I appreciate you guys getting on this Monday.
All right. Thank you very much,
you.
Dr. Kolby. And we'll talk soon.
All right, my man.